Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the cardiology, that is the infective endocarditis. So, if you see the definition of the infective endocarditis, it is a clinical condition which is characterized by the colonization of the heart valves with microbiological organisms. Okay, so it's a condition characterized by colonization of the heart valves with microbiological organisms, right? So that is the definition of the infective endocarditis, and these microorganisms, after colonizing the heart valves, they lead to the formation of friable infected vegetations, right? They lead to formation of friable infected vegetations, and after forming the friable infected vegetations over the valve, they cause the valve injury, right? They cause the valve injury. So that is the definition of the infective endocarditis. So it is a disorder which is characterized by the colonization of the heart valves with microbiological organisms, leading to the formation of friable infected vegetations and frequently the valve injury. Next, followed by that, you need to know what are all the clinical conditions where you have the presence of the friable vegetations. So the question is, which of the following have the most friable vegetations? Infective endocarditis, Liebman-Sachs endocarditis, rheumatic heart disease, systemic lupus erythematosus. Now, let me discuss what are all the clinical conditions where you have the vegetations and which is the vegetation most friable vegetation. So, if you see the friability of the vegetations, they are seen in clinical conditions like infective endocarditis, then followed by that, vegetations are also seen in NBTE. So, what do you mean by this word NBTE? NBTE stands for non-bacterial thrombotic endocarditis, right? And this non-bacterial thrombotic endocarditis, it is also called merantic endocarditis. And I will tell you where do you come across this non-bacterial thrombotic endocarditis. And other condition where you have the endocarditis is, that is rheumatic endocarditis. And followed by that, the endocarditis, it is also seen in SLE, that is systemic lupus erythematosus, and that we call it as Liebman-Sachs endocarditis. Right, that is called Liebman-Sachs endocarditis. So, out of all these, the most friable vegetation with highest risk of embolization, it is seen in infective endocarditis, right? So the infective endocarditis vegetations, they are the most friable vegetations, okay? And then followed by that, the next important friable vegetations will be non-bacterial thrombotic endocarditis vegetations. Then followed by that, rheumatic endocarditis vegetations are most friable, and Liebman-Sachs endocarditis vegetations, let me tell you, they are least friable. Right, they are the least friable vegetations. So that is about the friability of the vegetations. So the most friable vegetation is infective endocarditis vegetation, and least friable vegetations, they are the Liebman-Sachs endocarditis vegetations. So if you see this question here, which of the following have the most friable vegetations? That is the infective endocarditis vegetations. Now you need to know the distribution of the vegetations in the various clinical conditions what I have taught you. So I said you infective endocarditis, you have the vegetations, then followed by that non-bacterial thrombotic endocarditis, that is nothing but your merantic endocarditis. Then in clinical scenarios like rheumatic endocarditis and Liebman-Sachs endocarditis, that is SLE. Now let me discuss where will be the distribution of these vegetations within the heart. So the question is, characteristic endocardial lesions of SLE are most often located at atrial surface of the tricuspid valve, ventricular surface of mitral valve, left ventricular outflow tract obstruction, right ventricular outflow tract obstruction. So let me discuss the distribution of the vegetations and as well as the characteristic features of the individual vegetations. So first let me take up the discussion on the rheumatic fever endocarditis vegetations. These vegetations of the rheumatic fever, they are small vegetations and they are usually warty and verrucous. Right, they are usually warty and verrucous, and if you see the vegetations, they are usually firm, but occasionally they may be friable as well, but most of the times they are the firm vegetations, right, and occasionally they are also the friable vegetations. But the friability, if you see, compared to non-bacterial thrombotic endocarditis, they are less friable. Now, where is the distribution of this rheumatic fever endocarditis? The vegetations of rheumatic fever endocarditis, they are present along the lines of closure, right? They are present along they are present along the lines of closure. So that will be the rheumatic fever endocarditis vegetations, alright. Next, then followed by that, next we have the merantic endocarditis. I will also discuss where is this merantic endocarditis seen. Okay, but before that, this merantic endocarditis, let me tell you, this is also called non-bacterial thrombotic endocarditis. It is seen in hypercoagulable states. Okay, so let me discuss about the non-bacterial thrombotic endocarditis. It is seen in it is seen in the hypercoagulable states and also seen in malignancy, that is cancer, right, also seen in malignancy, that is cancer, and also seen in clinical scenarios where there is increased estrogenic state, right, where there is increased estrogenic state. And in which type of malignancy this merantic endocarditis is very common is, it is seen in case of promyelocytic leukemia. Right, it is seen in clinical scenarios like promyelocytic leukemia. So this is about the clinical conditions where you have the presence of non-bacterial thrombotic endocarditis. And if you take the vegetations of non-bacterial thrombotic endocarditis, even these vegetations, that is non-bacterial thrombotic endocarditis vegetations, they are small, right? They are small, but larger than those of the rheumatic fever vegetations. They are small, but larger than those of the rheumatic fever vegetations. And these vegetations, they are friable vegetations. But embolization, it is rare. And where is this particular non-bacterial thrombotic endocarditis vegetations present? They are present along lines of closure. Right, they are present along the lines of closure. That is about the non-bacterial thrombotic endocarditis vegetations. Now, followed by that, let me discuss about the Liebman-Sachs endocarditis. Liebman-Sachs endocarditis vegetations, they are nothing but the one which is seen in SLE. So, if you take the rheumatic fever endocarditis vegetations and non-bacterial thrombotic endocarditis vegetations, the size is, they are small. But if you take the Liebman-Sachs endocarditis vegetations, they are medium-sized vegetations. Right, they are medium-sized vegetations. And how are they? They are flat, verrucous, irregular. Right, they are flat, verrucous and irregular. And what is the consistency? They are usually firm in consistency. Right, they are usually firm in consistency and occasionally they are friable. Right, occasionally they are friable. The embolization, it is rare. Right, embolization, it is rare in case of the Liebman-Sachs endocarditis vegetations. Now, where are they distributed? If you take rheumatic endocarditis vegetations and non-bacterial thrombotic endocarditis vegetations, they are distributed along the lines of closure of the valves. Whereas the SLE, that is Liebman-Sachs endocarditis vegetations, they are distributed on the surface of the valves. Right, they are distributed on the surface of the valves and both surfaces may be involved, right, that is the atrial surface and as well as the ventricular surface. Okay, so both surfaces right, both surfaces may be involved, and among these both surfaces, right, that is the atrial surface and as well as the ventricular surface, both surfaces may be involved, most common being the under surface, that is most common being the ventricular surface. Right, the most common being the ventricular surface. That will be the distribution of the vegetations in case of the SLE, that is Liebman-Sachs endocarditis. Then followed by that, if you see the infective endocarditis vegetations, so a quick review of this SLE vegetations, they are medium sized, flat, verrucous, irregular, they are usually firm in consistency, occasionally friable, and they are present on the surface of the cusps. Both surfaces may be involved, most common being the undersurface, that is ventricular surface. Okay, next. Then you take the description of the infective endocarditis vegetations. So these infective endocarditis vegetations, they are large bulky vegetations, right? They are large bulky vegetations. And how do they appear? They are irregular, and they are friable, right? They are irregular and friable, most friable vegetations, and the chance of embolization is very high for this infective endocarditis vegetations. Now, where is the distribution of this infective endocarditis vegetations? These irregular vegetations, they are present on the valve cusps, right? They are present on the valve cusps. From the valve cusps, they can extend onto the chordae tendineae. Right, they extend onto the chordae tendineae. Now, out of all these vegetations, that is rheumatic fever, non-bacterial, Libman sacs and SLE, which particular vegetations are non-sterile and which vegetations are the sterile? So, if you see the description of this, rheumatic fever vegetations, they are sterile vegetations. Non-bacterial thrombotic endocarditis, sterile vegetations. SLE, sterile vegetations. Whereas infective endocarditis vegetations, they are non-sterile vegetations, right? And these vegetations, they contain bacteria, right? These vegetations, they contain bacteria. And these vegetations, let me tell you what they does to the endocardium or what they does to the valve. If you take rheumatic fever endocarditis vegetations, they are non-destructive valve perforation will be there, where in case of rheumatic fever endocarditis, that is non-destructive valve perforation. In rheumatic fever endocarditis, and it is the same in case of the non-bacterial thrombotic endocarditis as well, that is non-destructive valve perforation. Whereas if you take the Libman sacs endocarditis seen in SLE, it is destructive valve perforation. Right, destructive valve perforation, that is what you will see in SLE. Whereas the infective endocarditis vegetations, right, whereas the infective endocarditis vegetations, which are non-sterile vegetations, they are destructive, they do cause ulceration and they do cause perforation of the underlying valve. So they are destructive, right? They cause the ulceration right, and they also cause the perforation of the underlying valve. Right, so that is about the infective endocarditis vegetations, right? So this is the description of the vegetations in various clinical scenarios, right? So if you see the sites of vegetations, right, just now I have discussed, in case of, in which valves they are distributed, let me discuss that even. In case of the Liebman-Sachs endocarditis, that is in SLE, Liebman-Sachs endocarditis, the vegetations, where is the most common site? The most common site for vegetations in Liebman-Sachs endocarditis is the AV valves. That is atrioventricular valves. That includes mitral and mitral and tricuspid valve. Whereas if you see, the most common site for vegetations in non-bacterial thrombotic endocarditis, right, in non-bacterial thrombotic endocarditis, the most common site for vegetations is the mitral valve and less often aortic and tricuspid valve. Okay, right, most common will be the mitral valve, followed by that less often will be aortic and tricuspid valve, right? And then followed by that you see the rheumatic fever endocarditis vegetations. Right. So most common site for vegetations of rheumatic fever is the mitral valve, followed by that the aortic valve, right? Whereas you take in case of the infective endocarditis, the vegetations, they are more distributed over the aortic valve, followed by that the mitral valve, then followed by that the tricuspid valve. So this will be the distribution of the sites of vegetations in case of the infective endocarditis, right? Now, after having discussed about the distribution of the vegetations in various clinical scenarios, now let me discuss the infective endocarditis in detail. So before that, yes, you see this question what I have shown you just before. Characteristic endocardial lesions of SLE are most often located at. So I said you the vegetations in SLE, they are distributed on both the surfaces, that is the atrial surface of the valve and ventricular surface of the AV valve, but predominantly they are present over the ventricular surface of the mitral valve. Now, followed by that, you need to know what are the organisms which will cause the infective endocarditis. So, bacterial endocarditis is most commonly caused by alpha hemolytic streptococci, beta hemolytic streptococci, Staphylococcus aureus, cardiobacterium, Staphylococcus epidermidis. So, you need to know the pathogens in infective endocarditis, and then let me come back to this question again. So, the most common organism causing the infective endocarditis vegetations is the Staphylococcus aureus, right, Staphylococcus aureus, and followed by the Staphylococcus aureus, the next most common organism is viridans group Streptococci. That is Streptococcus viridans, then followed by that Streptococcus faecalis. Next we have coagulase negative Staphylococci. Right, coagulase negative Staphylococci. Then we have Streptococcus bovis. Next, we have the non-Hasek gram-negative bacteria, or we also have Hasek group of organisms. What is Hasek group of organisms? That includes Haemophilus, Actinobacterium or Acinetobacter, right? A is your Acinetobacter, C is your Cardiobacterium, E is Echinella, K is Kingella. Then followed by that, the next group of organisms will be fungal infections, that is fungi, and next Pseudomonas aeruginosa. Right, Pseudomonas aeruginosa. So these are the pathogens which will cause the infective endocarditis. Out of all these, Staphylococcus aureus, it contributes to almost 31% causes for the development of the infective endocarditis. Now, depending upon the organism, depending upon the valve which is being affected in infective endocarditis, we have the various types of the infective endocarditis, and that includes the acute infective endocarditis, subacute infective endocarditis, endocarditis occurring in IV drug abusers, and then prosthetic valve endocarditis. So, if you see the acute infective endocarditis, this acute infective endocarditis, it is caused by highly virulent organisms. Right, it is caused by highly virulent organism. And what is that particular highly virulent organism? That will be Staphylococcus aureus. And the valve which is being affected in case of acute infective endocarditis is the previously normal valve. Right, it is the previously normal valve which is being affected in case of acute infective endocarditis. Then followed by that, subacute infective endocarditis. So, in subacute infective endocarditis, the organism which will cause infective endocarditis will be moderate or low virulent organism. Right, moderate or low virulent organism. So this moderate or low virulent organism, that includes mainly Streptococci. Right, that mainly includes the Streptococci. And the valves which are being affected in case of subacute infective endocarditis is, it is previously injured valves. Right, it is the previously injured valves which are affected in subacute infective endocarditis. And if you see the endocarditis occurring in the IV drug abusers, endocarditis occurring in IV drug abusers, it is caused predominantly by organism found on the skin. Right, the organisms are the one which are predominantly found on the skin, and these particular organisms, they include Staphylococcus aureus, and then we have the Candida. These are the organisms which will cause the endocarditis in IV drug abusers. And in IV drug abusers, the valves which are most commonly affected are the right-sided heart valves. Okay, right-sided heart valves are most commonly affected. Why? Because the venous system into which the drug is being injected by the drug abusers, they are connected to the right side of the heart, right? The venous blood first enters into the right side of the heart. So the organism first enter into the right-sided heart. So the right-sided valves are commonly affected first. Then followed by that, let me discuss few more points related to this IV drug abusers. And if you see the age group, age of the patients affected in case of the IV drug abusers, they are usually the young males. Right, they are usually the young males. And the most common source of infecting microorganism will be the skin, that already we have discussed. And what is the most common valve which is affected? Most common valve which is involved is tricuspid valve. Right, it is the tricuspid valve. So please remember, in IV drug abusers, it is the tricuspid valve which is most commonly affected. Followed by that, there is involvement of the aortic valve, then followed by that, there is involvement of the mitral valve. So these are the valves which are affected in the infective endocarditis, the IV drug abusers causing the infective endocarditis. And murmurs, right, murmurs, they are frequently absent. Right, murmurs, they are frequently absent in endocarditis of the IV drug abusers. Okay, next. Now, after having discussed about the endocarditis of IV drug abusers, let me discuss the prosthetic valve endocarditis. But what about this murmurs? Why they are frequently absent? Let me tell you. These cardiac murmurs are almost always present in infective endocarditis. Right? They are almost always present in infective endocarditis. I'll also explain you why you have the presence of the cardiac murmurs. See, the vegetation, it is a verrucous vegetation and it's an irregular vegetation which is formed over the valves. And when the blood is passing through this vegetation, a turbulence is being created and thereby you have the presence of the murmur. And the characteristic feature of this murmur is, right, the characteristic feature of this murmur is, they have the changing murmurs. That means quality of the murmur right, that means the quality of the murmur keeps on changing from time to time in case of the infective endocarditis vegetations. But in case of the cardiac murmurs of infective endocarditis of IV drug abusers, right, of IV drug abusers, murmurs are usually absent. Right, murmurs are almost always present in infective endocarditis vegetations except in patients with the IV drug abusers. And the next important scenario is in clinical scenarios like early acute endocarditis. Right, early acute endocarditis. So in these scenarios, you will have the absence of the cardiac murmurs in spite of the underlying infective endocarditis. See, why is that in IV drug abusers you don't have the cardiac murmurs? Because in IV drug abusers, the murmurs, they are most commonly present on the right side. And the right sided chambers are like low pressure gradient areas. Now, because the pressure gradient across the valves is less, the murmur you don't listen that characteristically in case of the IV drug abusers causing the infective endocarditis. Now, followed by that, so we have discussed three types until now: acute infective endocarditis, subacute infective endocarditis, then infective endocarditis in IV drug abusers, then followed by that the prosthetic valve endocarditis. So, if you take this prosthetic valve endocarditis, prosthetic valve endocarditis is that where the infected vegetations, they appear on the prosthetic valve, which is called prosthetic valve endocarditis. And this prosthetic valve endocarditis, it may be, right, it may be an early prosthetic valve endocarditis, or it may be a late prosthetic valve endocarditis. So, early prosthetic valve endocarditis is that the symptoms appear within 60 days of valve insertion. Right, the symptoms appear within 60 days of the valve insertion, that is early prosthetic valve endocarditis. Where, what do you mean by the word late prosthetic valve endocarditis? Here the symptoms appear after 60 days of the valve insertion. Right, after 60 days of valve insertion, that is called late prosthetic valve endocarditis, right, after 60 days of valve insertion. Now, you need to know the organisms which will cause the prosthetic valve endocarditis. So, if you see the organisms which will cause the early prosthetic valve endocarditis, the most common organism is coagulase negative Staphylococcus, right, the most common organism is coagulase negative Staphylococcus. And apart from this, the other organisms which will cause the early prosthetic valve endocarditis, that includes the Staphylococcus aureus, then Enterococci, followed by that the Streptococci, that is Streptococcus viridans, right, followed by that Streptococcus viridans. So, these are the organisms which will cause early prosthetic valve endocarditis. Whereas, if you see the organisms which will cause infective endocarditis between 2 to 12 months, the organisms which will cause the most common organism, it is the same, right, the most common organism which will cause the infective endocarditis in between 2 to 12 months after the prosthetic valve insertion will be the coagulase negative Staphylococci. Then followed by that we have the similar organisms again, even Staphylococcus aureus, Enterococci, Streptococcus viridans, they cause the infective endocarditis in prosthetic valves in between 2 to 12 months. But the most common organism which will cause infective endocarditis vegetations of age group 2 to 12 months will be the coagulase negative Staphylococci. Whereas, if you take the, if you see the late prosthetic valve endocarditis, what is the most common organism? Most common organism which will cause late prosthetic valve endocarditis is Streptococci or Streptococcus viridans. right, the Streptococcus viridans, followed by that all other organisms, even your Staphylococcus epidermidis. See, what is your Staphylococcus epidermidis? Staphylococcus epidermidis, it is nothing but the coagulase negative staphylococci. Then followed by that, the other organisms are the Staphylococcus aureus, then enterococci, next followed by that the gram negative bacilli, right, then followed by that gram negative bacilli are the one which will cause late prosthetic valve endocarditis. So these are all the organisms which will cause the prosthetic valve endocarditis. So please remember now, until 12 months of prosthetic valve insertion, if at all if there is prosthetic valve endocarditis, the most common organism will be coagulase negative staphylococci, which is nothing but the Staphylococcus epidermidis. And if at all if there is development of infective endocarditis late, that is late prosthetic valve endocarditis, the most common organism will be the Streptococcus viridans, right? Now, you need to know the causative organism depending upon the underlying clinical scenario of the patient. Like for example, you take subacute bacterial endocarditis. Subacute bacterial endocarditis, like what will be the common organisms? The common organisms include Staphylococcus aureus and then the Streptococcus viridans. Then followed by that, in IV drug abusers or right-sided endocarditis, the most common organism will be the Staphylococcus aureus, and left-sided endocarditis, the most common organism will be enterococci. Right, the most common organism will be enterococci. Prosthetic valve endocarditis, up to 12 months period, it is coagulase negative staphylococci, and beyond 12 months period, right, beyond 12 months period, the most common organism which will be causing the prosthetic valve endocarditis will be Streptococcus viridans, right, will be Streptococcus viridans. And then followed by that, the native valve endocarditis, that is community acquired native valve endocarditis, the most common organism will be Streptococci. And if you see the healthcare associated infective endocarditis, the most common organism will be Staphylococcus aureus. Then what is the most common organism which will cause culture negative endocarditis? Culture negative endocarditis, the most common organism will be Granulicatella abiotrophia. Right, Granulicatella abiotrophia, and the other organisms include the Tropharema and as well as the Bartonella. Okay, so these are all the organisms which will cause the culture negative endocarditis. And you take SLE. In case of SLE, the vegetations are sterile vegetations, and they are present on the inferior surface of the valves. So they are mainly present on the ventricular surface of the AV valves, then compared to that of the atrial surface of the AV valves. And non-bacterial thrombotic endocarditis, here the endothelium damage leads to platelet fibrin thrombus formation. So in non-bacterial thrombotic endocarditis, it is also a sterile vegetation. And what does the vegetation contain? The vegetation contain platelet fibrin thrombus. Right? So that is about the story related to the causative organisms and as well as various clinical condition having the vegetations. So if you see this question now, bacterial endocarditis is most commonly caused by the Staphylococcus aureus, right? Next, followed by that, you see this question, a patient has prosthetic valve replacement and he develops endocarditis 8 months later. The organism which is responsible is Staphylococcus aureus, Streptococcus viridans, Streptococcus epidermidis has a group of organisms. So 8 months later, what is that I have discussed? Within 12 months of valve insertion, right? Within 12 months of valve insertion, please remember the most common organism will be Streptococcus epidermidis. So the most common organism which will be causing infective endocarditis of the prosthetic valve within 12 months will be Staphylococcus epidermidis, right? And this Staphylococcus epidermidis, it is also called coagulase negative staphylococci, right? They are also called the coagulase negative staphylococci, right? Next, then followed by that, let me discuss one more very important question, that is acute infective endocarditis with abscess formation is most commonly associated with Listeria, Staphylococci, Streptococci, Enterococcus. The most common organism which will cause the abscess formation will be the Staphylococci. So Staphylococci, we have discussed that it is a highly virulent organism, right? It is a highly virulent organism, and the infective endocarditis caused by the Staphylococci, it will cause the abscess formation within the valve and as well as the annulus. Okay, so there will be myocardial abscess, right? There will be myocardial abscess formation, and there will be also the annular abscess, and these patients with Staphylococcus aureus causing infective endocarditis, they have higher mortality, right? They have the higher mortality. So that is about the acute infective endocarditis with abscess formation is most commonly associated with the Staphylococcus aureus. Next, then followed by that, you need to know infective endocarditis in Austrian syndrome is Staphylococcus aureus, Staphylococcus epidermidis, Streptococcus viridans, Streptococcus pneumonia. So Austrian syndrome, it is caused by the Streptococcus pneumonia. This Austrian syndrome, it is also called the Osler's triad. Right? Austrian syndrome, it is also called the Osler's triad. This Osler's triad represents the association of pneumonia, right? Represents the association of pneumonia, then meningitis, then infective endocarditis. right? Then infective endocarditis. So that is what is your Austrian syndrome. So Austrian syndrome, which is also called the Osler's triad, that represents an association of pneumonia, meningitis and the infective endocarditis. So involvement of lung, involvement of brain and involvement of the heart. The three vital structures are affected in Austrian syndrome, which is also called the Osler's triad. Next question is, which of the following is least likely to cause the infective endocarditis? Staphylococcus albus, Streptococcus faecalis, Salmonella typhi, Pseudomonas aeruginosa. So the one which is least likely to cause infective endocarditis, it is the Salmonella typhi, right? Next, the next important discussion you need to know that this infective endocarditis, it is most commonly seen in individuals with an underlying cardiac lesions that will predispose to the development of infective endocarditis. So the question is, which of the following cardiac lesions is at highest risk of occurrence of the infective endocarditis? Atrial septal defect, mitral valve prolapse without regurgitation, valvular aortic regurgitation and then the mitral stenosis. So the valvular lesions which are having the highest risk, moderate risk and low risk, let me discuss that. So if you take the valvular lesions which are having the highest risk, they include the congenital heart diseases and as well as certain valvular heart diseases. So the one with highest risk include, number one, with prosthetic heart valves, right, the one with prosthetic heart valves, then followed by that the tetralogy of Fallot, patent ductus arteriosus, aortic regurgitation, aortic stenosis, mitral regurgitation, then coarctation of aorta, and next we have ventricular septal defect. So these are the lesions which have the highest risk of development of the infective endocarditis, that is prosthetic heart. And why these lesions they are at highest risk? Because across these lesions there is high pressure gradient, and because of this high pressure gradient there will be rupture of the endothelium on which there will be deposition of the thrombus, platelets, microorganisms resulting in infective vegetations. Then what are the moderate risk lesions? Moderate risk lesions which will cause the infective endocarditis include mitral valve prolapse with mitral regurgitation, then tricuspid stenosis, pulmonary stenosis and then the mitral stenosis. So TS, PS, MS, then followed by that TR, that is tricuspid regurgitation. So these are the moderate risk lesions for the development of infective endocarditis. Then you need to know what are the low risk cardiac lesions which will develop the infective endocarditis, right? That includes mitral valve prolapse without MR, right? Mitral valve prolapse without mitral regurgitation, then followed by that the ASD. These are the low risk cardiac lesions for the development of infective endocarditis. Now why these are considered as the low risk? Because the pressure gradient across these lesions is very less, and that is the reason why the chance of vegetation to develop across these lesions will be less. Okay. Now if the question is asked, among all these cardiac lesions, which is the most common lesion where there is development of infective endocarditis, right? That is MVP with MR. MVP with MR, this is the most common lesion right? This will be the most common lesion which will be responsible for the development of the infective endocarditis. So if you see this question. Which of the following cardiac lesions is at highest risk of occurrence of infective endocarditis? Atrial septal defect, mitral valve prolapse without regurgitation, valvular aortic regurgitation, and then mitral stenosis. So the answer is valvular aortic regurgitation. So these lesions, that is aortic valve lesion, they are at highest risk of occurrence of the infective endocarditis. Then followed by that, you need to know the clinical features. So we have discussed the organisms, and then we have discussed the cardiac lesions which will predispose to the development of infective endocarditis. Next, let me take up the discussion on the clinical manifestations. So it is infective endocarditis. So which particular manifestation will be most common? The most common manifestation will be the fever. Fever, it is present in almost 80 to 90% of individuals, right? Fever, it is present in almost 80 to 90% of individuals. Then on examination, what will be the most common finding? Heart murmur, this will be the most common finding, right? The heart murmur will be the most common physical examination finding. Then followed by that, the other features include the chills and rigors, anorexia, weight loss and malaise, myalgia and as well as arthralgia, then the back pain. These are the clinical features, but most common will be fever. And this particular fever, it will be a high grade fever. And this high grade fever is associated with chills and rigors. And what is the most common physical examination finding? That will be your heart murmur. And this particular cardiac murmur will be the murmur which will be changing from time to time. And there will be development of the new or worsened regurgitant lesions or regurgitant murmur. There can be an arterial emboli. See, these vegetations, they are like highly friable vegetations. They can rupture and they can get embolized to any vessel in the body. For suppose if they get embolized into the cerebral vasculature, they'll end up in cerebrovascular accident. For suppose if they get emboli into the digital vessels, they will develop the digital infarction. And there will be also development of splenomegaly in this individual, right? And there will be also development of clubbing. Clubbing, let me tell you, what are the cardiac conditions which will cause clubbing? The cardiac conditions which will cause the clubbing include cyanotic congenital heart diseases, right? Cyanotic congenital heart diseases, then followed by that the infective endocarditis. And occasionally, clubbing can also be seen in patients with the myxomas. And they also have the neurological manifestation, and that can be in the form of the cerebrovascular accidents. Peripheral manifestations include Osler's nodes, subungual hemorrhages, Janeway lesions, and then the Roth spots. So these are the features of the infective endocarditis. Right? These are the features of infective endocarditis. And most common feature is what? That is the presence of the high grade fever. Now, what will be the laboratory manifestations? And apart from that, you take the cutaneous manifestation. These individuals, they have the presence of multiple petechiae all over the skin. And laboratory manifestations include anemia. Anemia will be the most common finding. Please remember, anemia is the most common finding. Then leukocytosis, because it's an infective pathology. Microscopic hematuria, because these individuals, if the vegetations, once they emboli into the kidney, they will develop glomerulonephritis. And secondary to glomerulonephritis, they will have microscopic hematuria. And ESR is elevated because it's an inflammatory pathology. So markers of the inflammation, that is ESR is elevated, and as well as the C-reactive protein is also elevated. And in certain group of individuals, the rheumatoid factor will be positive, and you have the presence of circulating immune complexes, right? that is the antibody and then the antigen, they form the immune complexes and they will be circulating in various parts of the body. And the complement is utilized for the immune activity. So there will be decreased serum complement levels in these patients with the infective endocarditis. So now let me just show you a question. Osler nodes are seen at heart, knee joint, tip of the finger, anterior abdominal wall. So Osler's nodes are the one which are seen in patients with the infective endocarditis. And where are they distributed is they are distributed over the tip of the fingers and as well as tip of the fingers of where? Tip of the fingers of both upper limb and as well as the lower limb, right? That is what is your Osler's nodes. And these Osler's nodes, let me tell you, they are very tender, right? They are very tender and painful. Now in these patients with the infective endocarditis, you can observe or you can notice the presence of the splinter hemorrhages. So these splinter hemorrhages, they appear as red lineal streaks under the nail plates. So you can observe that here, right? The splinter hemorrhages, they appear as red lineal streaks under the nail plates and within the nail bed. And this splinter hemorrhages, they are seen in patients with the infective endocarditis, and the differential diagnosis includes the psoriasis, right? Differential diagnosis includes the psoriasis and the trauma. So these are all the conditions where you can have the presence of the splinter hemorrhages. Now let me just show you the Osler's nodes. So these are the Osler's nodes, right? You can see that at the tip of the fingers of both upper limbs and as well as lower limbs. These Osler's nodes, they are very painful. And where are they present? They are present within the pulp of the big toe, right? They are present within the pulp of the big toe. And these lesions, whatever you are seeing here, over the sole of the foot, they are Janeway lesions. Even Janeway lesions, they are seen in patients with infective endocarditis. But these Janeway lesions, please remember, they are non-tender. Whereas Osler's nodes, they are tender. And yes, so you can see that here, even this is also a Janeway lesion. Now, these patients, they can have the digital infarcts. So why is that they have this digital infarcts? Because these vegetations which are friable, they can shower or they can rupture as a septic emboli. And this septic emboli will go and get deposited within the digital blood vessels, wherein the blood supply to the digits will be impaired, and that will make the digit to be infarcted. Okay, so septic emboli with hemorrhage and infarction due to acute Staphylococcus aureus infective endocarditis. Next, now another important image that you can see here, this is a fundoscopic examination of the retina, and you can see the presence of a lesion. And this particular lesion, it is the Roth spot, right? This lesion, it is a Roth spot. Now, Roth spots, they are the retinal hemorrhages. Right? Roth spots, they are the retinal hemorrhages. Now, this particular Roth spots, they are seen in infective endocarditis. And apart from infective endocarditis, what are the other causes of Roth spots? So, if you see, I mean to say, other causes of Roth spots. Apart from infective endocarditis, Roth spots, they are also seen in patients with the SLE, systemic lupus erythematosus. Then we have a type of medium vessel vasculitis, and that medium vessel vasculitis is polyarteritis nodosa. Next, in severe anemia you can have the presence of Roth spots. Then followed by that, in leukemia you have the presence of the Roth spots. Then in patients with hypertension you can have the presence of Roth spots, and in diabetes mellitus you have the presence of Roth spots. So these are all the conditions where you have the presence of Roth spots. But what we are interested here, that the Roth spot, it is seen in infective endocarditis, and this particular Roth spots, they are the retinal hemorrhages, right? They are the retinal hemorrhages. Okay. Next. Now, yes, so this will be your Osler's nodes, which are present at the tip of the fingers of both upper limbs and lower limbs. And what did I tell you? These Osler's nodes, they are very painful and tender. Whereas if you take the Janeway lesions are the one which are present over the palm. And these Janeway lesions, they are non-tender. Then, yes, so you see this question, Roth spots are seen in infective endocarditis, rheumatic endocarditis, central retinal artery occlusion, typhoid. So, Roth spots are seen in infective endocarditis. And what are the other conditions? Like polyarteritis nodosa, severe anemia, leukemia, diabetes mellitus, and then hypertension, you can have the presence of the Roth spots. And these Roth spots, they are oval retinal hemorrhages with a clear pale center. Right, so that is your Roth spot. They have the clear pale center, and they are typically seen in patients with a subacute bacterial endocarditis. Now, how are these particular Roth spots formed? They are believed to be caused by immune complex deposition within the retina. Right, they are believed to be formed by immune complex deposition in the retina. So that will be the Roth spot. Now, after having discussed about the clinical manifestations and as well as examination finding in patients with infective endocarditis, let me discuss the criteria for infective endocarditis. So, the name of the criteria for infective endocarditis is the modified Duke's criteria. And in this modified Duke criteria, we have major criteria and then the minor criteria. Now, let me discuss what are these major criteria. So, we have two important major criteria, and these two important major criteria include, number one, 2 positive blood cultures. So, there should be more than or equal to 2 positive blood cultures for a microorganism that typically causes infective endocarditis, right? More than or equal to 2 positive cultures should be there. And for majority of the organisms, there should be more than or equal to 2 positive blood cultures. But if you see this organism, that is Coxiella burnetii, right? If you see this organism, that is Coxiella burnetii, even single culture, right? Even if the single positive blood culture, if it is there, that is enough for the positive blood culture to be taken as a major criteria, right? So even single culture is positive, we take it as the major criteria for Coxiella burnetii, right? The one which will cause the Q fever. And the second important major criteria is evidence of endocardial involvement. Right? Evidence of endocardial involvement. Okay. So this evidence of endocardial involvement, it is documented by echocardiography. Right, it is documented by echocardiography, and this endocardial involvement, it will show you the presence of, echocardiography will show you the presence of the definite vegetations, right, that will show you the presence of the definite vegetations. Next, will show you the presence of the myocardial abscess, and this echocardiography will also show you a new partial dehiscence of the prosthetic valve, right, or prosthetic valve dehiscence can be seen on echocardiography. And another important abnormality that you can see in echocardiography to be considered as the major criteria of infective endocarditis is new onset valvular regurgitation. Right, new onset valvular regurgitation. So this will be the evidence of the endocardial involvement. So two positive blood cultures that should be there, or for Coxiella burnetii, even if single positive blood culture is there, it is fine, and then evidence of endocardial involvement that is documented by echocardiography, right. Next, now let me discuss little detail about this blood cultures. So if you take this blood cultures, you need to collect 3 sets of blood cultures, right. 3 sets of blood cultures are recommended before starting antibiotics to maximize the microbiologic diagnosis. This is very, very important. You need to take the blood cultures before starting antibiotics, but after starting antibiotics, if you take the blood culture, you will have the culture negative endocarditis. And in order to maximize the yield, right, in order to maximize the